So when you think about block 1, and we talked about cardiac murmurs, we talked about how you have the different valves in the heart, but then we talked about how you can have either a stenosis type of murmur, where there is a resistance to actually opening that creates this turbulent blood flow that creates the auscultatory findings. But then you also have the regurgitation murmurs, where you're having flow of blood going in the wrong direction. So, so those are like the two flavor of heart valve murmurs that we are going to encounter. And what contributes to this is when you have that regurgitation, you're not getting that adequate closure of the leaflets of the valve. So when it closes, and it should prevent flow from coming back to where the blood came from, what ends up happening is you have this opening still there, and now blood is going in the wrong direction. You don't have that one-way valve anymore. On the flip side with stenosis, you can see the valve looks kind of diseased, it's thickened, it's calcified. And you can imagine, kind of think of it as like this is scar tissue. Does scar tissue move freely? And the answer is no, right? That's what's happening to the cardiac valves when we have a stenotic murmur. If you like mnemonics to help you clarify which ones are going to be systolic murmurs, the mnemonic Mr. Pass, the M, the R, the P, the A, the S, and the S, wins MVP, most valuable player. That's a mnemonic to help you remember which cardiac murmurs, which valvular murmurs are systolic. And then Ms. Arts is a mnemonic to help you remember which ones are diastolic murmurs. Okay. And it's important to differentiate those two, because not only does it help you appreciate which murmur you're hearing, whether it be a regurgitation or stenosis murmur, but it's also important when it comes to the management side of things, whether it's systolic or diastolic. Okay, and we'll talk about that on the next slide. The other thing that's important to remember when we talk about murmurs is the grading of the murmur. So systolic murmurs go from 1 to 6, and there is a meaning behind saying this is a 3 out of 6 systolic murmur. So knowing that is going to be important that way, because you can communicate what you're hearing, but from a management, on the next slide again, we'll visit why grading this is important, because your management could be very different depending on the actual grade of that murmur. Diastolics just go through 1 to 4. So don't say you have a 5 out of 6 diastolic murmur, because there is no such thing as a 5 out of 6. It just goes up to 4, and that's it. So algorithms, great, kind of summarized it. If you have a diastolic murmur, that is automatically pathologic. Okay. If you have a continuous murmur, so it goes through both systole and diastole, that is a pathologic murmur. If it is pan-systolic, pathologic, and then late is pathologic, sorry, late systolic murmur is pathologic. But then the last thing is a loud murmur is pathologic. And what makes what meets the definition of loud is if you graded this as a 3 out of 6 or greater, that is pathologic. So you can see if I got a 2 out of 6, which looking back, what does a 2 mean? It means faint but immediately audible. Compare that to a 3 out of 6, which is easily audible or easily heard. That distinction makes you have to work them up. If you say it's a 3 versus it's a 2, maybe we don't need to work it up, and it could be just a normal benign cardiac murmur. Okay, so this algorithm or this flow chart basically just boils down to if I have a diastolic, holosystolic, continuous murmur, or it's loud, get an echo. Okay. or if you're questioning, get an echo. That's what most of us do in primary care anyways, because I could not tell you the difference between a 2 and a 3 systolic. Okay. I don't hear enough murmurs if you have to differentiate the two. Now, the other thing that we find when we talk about and auscultate cardiac murmurs is there is typically there's a typical configuration that goes along with these murmurs, where if you have like an aortic stenosis or a pulmonic stenosis murmur, they tend to have this crescendo-decrescendo pattern. If you have mitral or tricuspid regurg, it tends to be this pan-systolic or holosystolic murmur. Mitral valve prolapse is this late systolic murmur. Aortic and pulmonic regurg has this kind of decrescendo pattern. And then mitral and tricuspid stenosis tends to have this decrescendo-crescendo pattern. A lot of information, and we'll talk about why, when we talk about each one of these valvular diseases, we'll talk about why we see this configurational change in that murmur. Okay. But before we can jump in and actually start talking about specific valvular diseases, we have to talk about rheumatic fever and rheumatic heart disease, okay? This is not a disease that's common in first world or industrialized nations because we have ready access to healthcare, we have ready access to antibiotics that can treat streptococcal infections, but this is globally a major cause of cardiac disease, especially amongst our adolescent populations. So, why are we going to spend time talking about rheumatic heart disease, rheumatic fever, even though we don't see much of it in our patient population here? Well, you're all military, wearing a uniform. Where are we deploying to? Are we deploying to first world countries? Typically not, right? So, what do we also, when we are deployed, what are the types of missions? Yes, we have the combat missions, but there is the hearts and minds kind of thing. There's the, if you're in the Navy, going out on the hospital ships and going to, Caribbean or Pacific Islands, where they don't have this healthcare. So this is still something, because of our unique practice, we're going to see. Okay? So we're going to talk, and we're going to spend some time talking about rheumatic fever, rheumatic heart disease, before we jump in and start talking about the individual valvular diseases. And you'll see when we start talking about common etiologies, why having that background in rheumatic heart disease and rheumatic fever is important. So what exactly is rheumatic heart disease or rheumatic fever? Kind of think of this as, this is a continuum of strep throat infections, or a group A strep infection, okay? So what happens is, a child gets a strep throat infection, which, just think about how common that is, even in our society, to get strep throat, right? So they get strep throat, they either don't go to the doctor or go to the healthcare provider, or they don't get an antibiotic prescribed. Then they have an increased risk of 2 to 3 weeks later, they start to develop rheumatic fever. And there's a constellation of symptoms that go into rheumatic fever. Having rheumatic fever then puts this person, or puts this child, at risk in 10 to 30 years from now, having permanent damage done to cardiac structures, especially the valves. And now, if you 5 to 15 years of age is a common age that folks get strep. So now you're talking about, 10 to 30 years, you're talking about 15 to 45 age, all of a sudden they're having a permanent disabling cardiac disease. So you can see how this could impact a much younger population that should not otherwise have cardiac disease. And it simply comes down to they didn't get their strep throat infection treated. Okay. So it's easily preventable, provided they get the care that they need in a timely fashion. So let's talk about acute rheumatic fever. So This is the version on the spectrum where you get that delayed 2 to 3 week after a strep throat, group A strep infection, where you start to get a constellation of symptoms that develop, and part of those symptoms is actual damage to the cardiac structures, i.e. the valves, which typically affects the mitral valve. Then aortic valve is the second most common, and then tricuspid is the third most common valve damaged from acute rheumatic fever and rheumatic heart disease. You can see the incidence globally is 19 in 100,000, which if you subtracted just the industrialized nations, that value would be so much higher, because in the US, our rheumatic fever incidence is 1.1 to 1.5 per 100,000. So you have a 19 times higher risk globally of having this disease, simply because of lack of access to healthcare, lack of access to prescription antibiotics to treat streptococcal infections. And you can see there 3% occurrence of rheumatic fever in folks who do not get treatment. Okay, doesn't seem a lot, but 3% is still a high percentage when we talk about medicine, right? We talk about risk of surgical infections being 1%. You can see that this is much higher than that. So 3% is still quite a high number when we talk about medicine. So how are these patients going to present to you with rheumatic fever, acute rheumatic fever? Initially, it could be very vague, non-specific things. How many different diseases does a 5-year-old get that's fevers? How, especially if they're going to daycare, right, or kindergarten. So, oh, they got chills. Okay, again, how many different diseases, what's going to lock you in that this is rheumatic fever? Fatigue, migratory arthritis, all of you. This sounds like COVID except for the lack of smell and taste, right? So, it can be very difficult to diagnose a patient, especially a kiddo, with rheumatic fever, which leads to this being not treated, which then portends to a worse outcome, worse chances of them developing the rheumatic heart disease in 10 to 30 years. So what can we appreciate in our patients who are presenting with acute rheumatic fever that might ping us or make us think of this disease? The Jones criteria helps us with that, okay? I know we throw out all these, certain criteria. We talk about Duke's criteria, Dallas criteria. I'm going to throw Jones criteria into this. But there's a specific thing, or specific symptoms that we're looking at that diagnose somebody with rheumatic fever. And the criteria for it is, first and foremost, they have to have a history of strep infection, so group A strep infection. And we're going to talk about how you can prove that. If they didn't go and see a provider for their strep throat 2 to 3 weeks ago, how can we diagnose them today that they had a strep throat infection recently? And then once you've determined that they have in fact had a strep throat infection recently, then they can have either 2 major criteria to be able to meet the definition of being Jones positive, or they have 1 major and 2 minors. We'll talk about the majors over the course of the next slides individually, so I'm going to skip this section. But looking at the minor criteria, okay, you've got an infection going on, right? Arthralgias is a minor criteria. Again, how many infections cause arthralgias? Quite a few. So that's going to be easy criteria to meet, right? Fever, again, you've got an infection, and kiddos like to spike fever just by looking at them, right? It's not like adults, older folks, where it's, you have to be really sick to actually spike that fever. Kiddos will spike fevers for even the mildest viral infection that they get. It is an inflammatory process, so they're going to have elevated ESR-CRPs. Again, how many conditions have elevated ESR-CRPs? So you can see it's not that hard to meet that criteria of the minor criteria, having those 2 minor criteria plus 1 major to diagnose rheumatic fever. So let's talk about the major criteria individually. So fortunately, if you take Jones and use that as a mnemonic, it actually tells you what the major criteria are. So J for Jones stands for joints. So you have a migratory polyarthritis that typically affects the large joint. So it's not my little pinky joint that hurts. It's going to be elbows, it's going to be knees, it's going to be hips. That's where they're going to feel that migratory pain associated with this. And this is the most common symptom your patient with rheumatic fever is going to experience. About 75% of patients are going to have this. Okay. And then, even if you don't do any treatment, typically this pain will go away within 4 weeks. Okay. Moving on, let's take that O and let's make it now in the shape of a heart. This is carditis. So now, what's happening that's triggering this carditis or this inflammation of the heart is the immune system tries to attack the antigens of the group A strep. Well, those are similar to the cardiac antigens. So kind of think of this becomes an autoimmune disease because my own immune system starts to attack my heart because of that similarity between antigens of the bacteria and the heart. Okay. And it can cause a inflammation. So you're going to have like endocarditis, myocarditis, pericarditis. You're going to have friction rubs associated with pericarditis and everything like that with this. But most importantly, which makes it kind of unique from pericarditis, is you also then start to have a new murmur that could be stenotic or regurgitant in nature. Okay? Because of this inflammatory response attacking my valves, it disrupts the normal function of that valve of opening and closing properly, and you develop this murmur. Other things it could be, okay, because of the inflammatory process, you might have tachycardia associated with this, especially if the heart's having to compensate for poor function. It's going to try to maintain that cardiac output by increasing the heart rate. Because of the inflammation, the heart's not going to want to squeeze like it should. So you might see an impaired function of the heart. And then the murmurs, they tend to be transient in nature. So this is not a murmur that they're permanently going to have. Once that inflammatory process goes away, then those murmurs will disappear, at least in this immediate setting. Continuing on with our Jones, so the N for Jones is subcutaneous nodules. These are firm, painless nodules on elbows, knees, and Achilles tendons. These will kind of look like ganglion cysts, but these are not attached to the tendon sheaths like ganglion cysts. So when they move a digit, it's not going to move with it because it's not attached to that tendon like ganglion cysts are. Okay. Fortunately, though, this is the least common of the symptoms that your patient with rheumatic fever is going to experience. Erythema marginatum is your E in Jones. This is still unusual or rare. It's more common than the nodule part, but still less than 5% of your patients with acute rheumatic fever are going to have this rash. And when you look at this rash, this looks very similar to a fungal infection. So this could be misdiagnosed as like jock itch. And what can kind of help you differentiate this kind of rash from a tinnial infection is they tend to be, fungal infections tend to be very pruritic. They're itchy, right? This is a non-pruritic rash. So that can maybe help you differentiate this being a fungal infection from this being erythema arterinarum. And then our S is probably the most concerning of the Jones symptoms, major criteria symptoms, and that's the Sydenham's chorea, which is this rhythmic, uncontrolled kind of tic or movement disorder that can develop in 20% of your patients with acute rheumatic fever. And they'll just be, I don't know if you've ever seen anybody with one of these tic kind of movement disorders, but they're just sitting there and their body's just uncontrollably just kind of twitching and moving around and everything like that. And that typically happens in folks with, or at least 20% of your patients with rheumatic fever. What's interesting is these tics, these movements actually will stop when they're sleeping. So at least they can get sleep, right? Some of the other tic movement disorders, they don't necessarily stop with sleep. So that's the major criteria for the Jones. Let's revisit the first criteria to say somebody has rheumatic fever, which is the evidence of a group A strep infection. So if they didn't come to see a medical provider 2 or 3 weeks ago to get their rapid strep test or their throat culture done, how can we diagnose this patient with a recent strep infection? So you can still do the rapid strep test, you can still do the throat culture test just to see if it happens to be still positive. But you do have antibody testing available to you to see if these titers are elevated, which would indicate a recent strep infection. Okay? So antibody testing, if you're concerned for rheumatic fever, but your rapid strep test is negative, your throat culture is negative, then you can do this antibody testing for these 3 things to see if there is evidence of that recent strep A infection. Other things, if you're still like, I don't know, is this or is this not? Okay, yes, we could do a heart biopsy, and the finding histologically that you might see is this thing called Aschoff bodies, which just means you have focal fibrinoid necrosis surrounded by inflammatory cells that form into fibrous scar tissue. So Aschoff bodies, that's all you need to know for rheumatic fever. But so there is something that we could do to diagnose this. Ancillary studies may not be useful, but you may see cardiomegaly, especially if there is a pretty significant inflammatory process going on. If there's dilation of the heart chambers themselves because of the failing heart, then you might see that enlarged cardiac silhouette. You may have heart blocks because if that inflammation starts to affect the conduction system, you may see on EKG a variety of heart blocks. So how are you going to treat somebody with acute rheumatic fever? Well, first and foremost, if this is a group A strep-caused infection, let's make sure they don't have any more group A strep circulating around. So let's give them antibiotics that target group A strep to eradicate all that bacteria out of their system. And then they're going to need some kind of anti-inflammatory therapy, which typically we like to do aspirin, even in kids. And you can see it's going to be a high dose of aspirin. This is not your 81 milligram of aspirin that you're given as a daily aspirin like your grandparents take or whatever. This is going to be large doses of aspirin. And you may be asking, well, what about Reyes syndrome? Chances of that developing are much lower than them having long-term consequences from this. So a risk-benefit discussion is the risk of Reyes is lower than the benefit of them having this high-dose aspirin. So kids will get aspirin in this condition. Okay. And then the concern is if we go to treat, what are we trying to do? Well, we're trying to get rid of that group A strep bacteria. We're trying to give symptomatic relief of the acute things. So those acute Jones criteria, we're trying to get rid of those, because especially if you have a little kiddo with the Sydenham's chorea, how impactful is that going to be on their life if they're having that movement tic disorder kind of thing, you know? So let's go ahead, and that's one of the goals with treatment for this. But ultimately, if this is like in a 5 or a 6-year-old who had strep throat, what are the chances of them having strep throat again? Pretty high, right? If they already had strep throat once, high chance of this happening again. But if they already had strep throat once that led to acute rheumatic fever, now you increase the chances and the risk of them having acute rheumatic fever again, which then puts them at a much higher risk of developing rheumatic heart disease 10 to 30 years from now, right? Where you have this permanent damage that occurs to cardiac structures. So if you have somebody who happens to have had rheumatic fever, they could be on prophylactic antibiotics, which of like a penicillin, which could be them taking a daily penicillin or a monthly shot. Kind of depends on what. But this is not something that they're just going to take this for a 6-day, 10-day, 14-day kind of thing. This is something that they're going to do for 10 to 40 years, just kind of depending on how severe their symptoms were. Because we want to make sure that we're getting them out of that age range of where folks get strep infections, so that they don't have a recurrence of rheumatic fever. Okay. Yeah.
So once they're out of maybe a particular age range, can you take them off antibiotics?
Yes. Yeah. So kind of depending on the severity, so that 10 to 40, that 20 to 40 year range, that kind of depends on how severe were their symptoms. Was it just they had the polyarthritis? Okay. They didn't have any of the other symptoms? Okay. But if they had carditis and they were full-blown heart failure that led to hospitalization, invasive monitoring, all that kind of stuff, then I might want to be a lot more cautious with them because they had such a severe reaction to this condition.
You might get to this later. Is there an impact, or how much of an impact does a tonsillectomy have on getting strep?
I don't know the answer actually to that, because it's not a recommended thing. But I don't know. I have to look in the literature to see what does that increase or decrease the incidence of that if they've had a strep infection during the tonsillectomy. So I don't know the answer actually to that. I'll look that up and get back to you.
Thanks.
All right. So let's go back to our continuum of strep infections, and we talked about the middle column, the acute rheumatic fever. Now let's fast forward. This person didn't get the appropriate care for the rheumatic fever, and now 10 to 30 years go by, and now they're coming in with rheumatic heart disease. And this is, now you have a permanent damage to the cardiac structures, particularly the heart valves. We said in the acute rheumatic fever with the carditis, yes, you're having this affecting the cardiac valves, but it's a temporary thing. Okay? Yes, you have this inflammatory reaction that causes the valve to act impaired, but then it goes away. Once that inflammatory process gets better, that impact on the valves goes away. But in rheumatic heart disease, this is now a permanent damage affecting the valves. That leads to it can either have a stenotic component to it, or a regurgitant component, or both. So you may end up having a stenosis with a regurgitation occurring in these patients. And you can imagine the pathophysiologic functional impacts that occur if you have both a stenotic and a regurgitant kind of component valvular disease. But the most common valve affected is going to be your mitral. Second most common is going to be your aortic, and then the third most common is going to be your tricuspid valve. So remember that when you're talking about common etiologies of the different valvular heart diseases, if you're thinking mitral, be thinking of rheumatic heart disease. Questions about rheumatic heart disease or rheumatic fever?
Stenosis or regurgitation more common?
The literature doesn't really break that down as far as, stenosis is this percentage or regurgitation is this percentage or mixed is this. I haven't seen any of that in my research. That would be an interesting thing to see what's more common, but really both can occur. So let's move on and let's talk about the mitral valve today. We're going to talk about the other three valves on Monday, but we're going to focus on the mitral valve today. So we're going to first start talking about mitral stenosis. So you have that calcification, that resistance to opening in the first place. And typically what you're going to see is much more common in females as opposed to males, which is kind of unusual because a lot of cardiac conditions we kind of think of a higher incidence prevalence in males, but this is one where there is a higher female predominance. Typically, this is going to affect younger populations, especially in developing nations, third world countries, because of rheumatic fever being the most common globally causing this. So if we said rheumatic heart disease is 10 to 30 years after rheumatic fever, and you have a 5-year-old who got rheumatic fever, we're now talking about 15 years of age, they could have this permanent damage to their mitral valve. Okay. So in areas where rheumatic heart disease, rheumatic fever is common or more common, that age of onset of this condition is much lower. Now in industrialized nations, that rheumatic heart disease drops down on this list, and now you're maybe thinking about calcifications, annular calcifications, so kind of chronic changes, which is going to be a much older population that's experiencing this. So what's the functional pathophysiologic impacts of having this resistance to open that valve when it should during diastole? Well, what ends up happening is that resistance means I'm going to have to increase my pressure in the atria, the left atria, in order to open that valve in the first place. So now that atria is experiencing a much higher pressure than it should, just to open that valve. The problem is that pressure, that increased pressure, is not going to stay just within the left atria. It's going to back up in the plumbing, right? It's going to back up into the lungs. And now you're going to have increased pressure in the pulmonary system, which then leads to the fluid extravasating out, and you start getting that pulmonary vascular congestion leading to fluid within the lungs and all those things. So that's the long-term outcome and concern with mitral stenosis, is that's going to lead and impact the lungs for it. Now, some conditions that might actually make this condition worse. This patient develops AFib. Now I'm losing my atrial kick, which is the thing that generates the highest pressure right within the atria. So if I lose that, now I'm having even less blood leaving the atria going into the ventricle, which means now it's going to back up into the lungs even more. So if you have a patient with mitral stenosis and they have AFib, this maybe is somebody who, instead of rate controlling them, we might want to rhythm control them and get rid of that AFib in the first place, so I can restore that atrial kick and restore that flow out of the atrium into the ventricle. Conditions that cause tachycardia. also is concerning because it decreases that diastolic filling time. If I'm already having resistance of diastolic filling, and now I decrease that time allotted to be able to achieve that filling of the ventricle, then that's going to reduce, and now I'm going to have that backup of blood going from the left atria into the lungs, and then even that can then impact the right side of the heart. And then pregnancy, just with the shifts, the fluid shifts and stuff like that, you can see with pregnancy that increased preload, so increased venous return, increased volume, affecting that left atrium. It's going to back up and cause that. So these are things that can make mitral stenosis worse, or the impacts of mitral stenosis worse. So if you're having this pressure and this backup in the lungs, it should make sense that a lot of the symptoms that our patients with mitral stenosis may display are going to be pulmonary based, right? So progressive dyspnea on exertion, reduced exercise capacity because they're not getting that oxygen exchange right, they're not circulating that oxygenated blood properly, fatigue, orthopnea, so they can't lay flat kind of thing, right-sided heart failure. So not necessarily like specific symptoms of mitral stenosis, but it makes sense that the pulmonary system is going to bear the burden of this condition, and you're not going to have that oxygenation and that working properly for you. On your physical exam, you're going to see or could auscultate this decrescendo pattern. And the reason for this is kind of think of it as a subway car that's filled with a bunch of people, and the doors open. Of course, everybody wants to get out at once. Well, you're going to be bumping into each other, and so that you're going to have a louder sound as you have more blood trying to get through that narrowed opening, right? But then as that flow occurs, now you have less people trying to get out of that subway car. The amount of bumping into each other is going to decrease. So in your murmur, you're having that decrease in turbulent blood flow, and so you get that decrescendo pattern. Well, now all of a sudden I get my atrial kick, and now my pressure jumps, and now all these people are running to the same door at the same time, and they're bumping into each other, and that makes that murmur louder. Okay, so that's why you get this decrescendo pattern and then crescendo, because you get that atrial kick. Okay. And typically, you also may appreciate an opening snap with this, because again, that resistance to opening because of the stenosis, you have to exert higher pressure, higher pressure, higher pressure, then all of a sudden you exceed that pressure to open that valve, and it's going to quickly swing open. And so you get that snap kind of sound and then murmur. So. And then you're going to be wanting to listen in the mitral auscultation site for this. It is best heard in with a low frequency sound, so you're going to get the bell of the stethoscope. So it's a low pitched, so best heard with that bell of the stethoscope. On your ancillary studies, what could you experience or what could you see? Well, if I look at my EKG, because that left atria is dealing with all of this extra pressure, extra volume, you end up getting a left atrial enlargement that you can see on your EKG. So you're going to have this P mitrale appearance for your P wave. If this is bad enough and it starts to affect the right heart structures, then you might start to appreciate a right ventricular hypertrophy or a right atrial enlargement or a right axis deviation associated with it. So, so these are the kinds of things that you might see on your EKG. Chest X-ray really is going to be kind of, let's look at the pulmonary impacts of this condition. So you may see that vascular congestion, the curly V lines, and those types of things that you learned about in radiology last semester. But your test of choice is going to be your echo, because this is a valvular disease, echo is your best cardiac test to determine what the heck is going on, right? And the classic finding on echo with mitral stenosis is going to be a fish mouth deformity. And what it is, you can kind of see on this, is because of all that calcification that's building up into that valve, it's thickening the valves, which kind of gives you the same appearance of a fish mouth. Okay, so not a very creative way of how we came up with the fish mouth deformity, but it looks extremely similar, right? So how are we going to manage these patients who do have a mitral stenosis? Well, this is a volume pressure problem. That at least some temporizing kind of things that we can do would be, let's decrease our preload or our venous return. So let's decrease our volume. And we do that with like salt restriction. Let's give them some diuretics so they're, instead of circulating all this volume, now they're getting rid of it and eliminating it from the body. Let's give them beta blockers. And the reason you do beta blockers in this case is, let's keep that heart rate low so that I have an increased diastolic filling time. So I can maximize the amount of blood going from the atria and into the ventricle. Digoxin for rate control in AFib patients, anticoagulants if they do have AFib. So there's some secondary kind of things that they might need. But ultimately, especially if they're having symptoms, we're going to have to do something more invasive in order to treat this than just salt restriction and diuretics. We're going to have to do something about that valve and the problem, that resistance to opening of the valve. So today, the preferred treatment is to do this percutaneous mitral balloon valvotomy, which is a really long name for basically we pass a balloon through the mitral valve, I inflate it, and then I pull through. And I basically am breaking those adhesions of the valve leaflets apart so that it can freely move again. So you're kind of breaking that scar tissue that formed with it. But there are complications with this. So the one way you have to gain access to this is you actually punch a hole through the atrial wall to go from the right atrium to the left atrium and then into the mitral valve. So you may, that hole that you created may not heal. So now you have a defect, an atrial septal defect. If I do this procedure and one of those calcifications that's large enough breaks off, it gets sent to the brain circulation, then it can cause a stroke. If I rip through this and now instead of letting those valve leaflets close on their own, I might have regurgitation. And then of course, anytime you're threading wires and stuff like that into sensitive, weaker kind of structures, you run the risk of punching holes through that structure. So you may have a cardiac perforation. So this procedure, even though it is preferred, there are complications associated with that. So let's take a 10-minute break and then we'll talk about heart valve replacements. Percutaneous mitral balloon valvotomy, but there are risks associated with doing this procedure, even though it is preferred. So that might mean that your patient may not want to take that risk, or maybe they're not a good candidate to do this procedure. So what else can we do to fix their mitral valve? Well, we can actually go in and do an open heart surgery and delicately kind of cut out the leaflets and stuff like that. That's what that open commissurotomy is. Or I can just replace the diseased valve entirely with a different heart valve, a synthetic heart valve, a prosthetic heart valve, which there's two kind of flavors associated with this. So you can get a biologic, which typically we think of this as being, we took a heart valve out of a pig, so it's like a porcine, and made it and put it in, or even cadavers. So that would be a biologic heart valve. Or I could just use synthetic mechanical kind of thing, where I'm using like carbon-based materials, and now I have this truly kind of synthetic valve that I can put in instead. And there's advantages and disadvantages to the two options. So you really have to kind of consider your patient when you are recommending, which kind of, as a primary care PA, you're not going to be recommending this, but as a primary care PA, there is going to be long-term management requirements that you're going to have to be familiar with, okay? So the advantages of using the biologic valve is it's biologic. It's unlikely to form clots. Because your heart valve normally right now does not want to form a clot, right? So that is the main advantage of using a biologic heart valve is it decreases, or you get a much lower risk of clot formation. So these folks don't need to be on anticoagulation. So this would be like your elderly patients who are falling all the time. Maybe they're an MMA fighter and they want to continue their career. Maybe they should be put on, maybe they should get a biologic. The downside of the biologic is it doesn't last for very long. So, within 15 years, 50% of biologic heart valves are going to fail. So if you have a 80-year-old who gets this, because they fall all the time, they get a biologic, what are the chances they're going to get to 95? Unlikely, right? Life expectancy, they're kind of at it at the 80, right? Could they? Absolutely, but unlikely. Compare that now to a 23-year-old. What are the chances that they're going to or still be alive 15 years later? And the answer is very high, right? So maybe biologics should be held out for our elderly populations and not for our younger populations, right? Mechanical valves, on the other hand, they last much, much, much longer, okay? The video, or the news story I wanted to show you was this lady had a mechanical heart valve, 2 mechanical heart valves, and they lasted for almost 50 years before she had to get heart transplant done because the disease just kind of got worse and her heart was starting to fail. So, but she had her mechanical valves for almost 50 years. So the mechanical valve is going to last much, much longer, but now you've got this foreign body, this metallic or this carbon-based foreign body in there that is going to encourage blood clot formation on it, on the surface of it, right? So these folks, if they get put on, if they get a mechanical heart valve, they are going to have to be on anticoagulation for the rest of their life while they have that heart valve in place, okay? So that is the disadvantage. Even though it lasts longer, it also encourages blood clot formation and they need anticoagulation for the rest of their lives. And remember, DOACs are not an option because they are not indicated for mechanical heart valves. Yeah, so warfarin would be your preferred option for these patients. So now you got all the additional issues with coming in every other day to get your INR tested, not being able to eat vitamin K rich foods, and all those other things. So, yeah. So there is some downside. Now, if you remember from block 1, we also talked about one of the risk factors of developing infective endocarditis is heart valve, mechanical heart valve, artificial heart valves, right? So these folks are going to be at risk of infective endocarditis. So if they undergo a dental type of procedure, they may need prophylactic antibiotics as well. So you can kind of see making the determination to replace the valve is not necessarily an easy one. There's other things that you're going to have to do or consider if the decision is made to replace a heart valve instead of doing that balloon valvotomy procedure and the accepted risks with that. So which one do you put in your patient? It's really going to have to be a discussion with your patient to determine, based on their lifestyle, based on life expectancy, based on their personal preference, which of these would they like to have, is important. So. questions about mitral stenosis?
Did everybody get surgery right off the bat?
Not everybody. So if they were to elect to get the percutaneous mitral valve balloon valvotomy procedure, that could actually just take care of it and then be done. But there is a group who either don't want to deal with the potential complications with that, or maybe they've already had it and it kind of recurred. They go in and then do the valve replacement. Okay. So mitral regurg. So we said regurgitation is when you don't have the leaflets of the valve closing like they should. So now you don't have that one-way blood flow integrity anymore. And now you have blood going in the opposite direction of what it should be. Which, if we're talking about mitral regurg, now we're talking about it going from the left ventricle to the left atria, not the right atria like the test out today, but to the left atria. Okay, so mitral regurg, more common in women than men, similar to mitral stenosis where you have higher female predominance. But there's lots of things that can cause this. Okay. But when you're talking about the regurgitation murmurs for valvular disease, the one thing you have to factor in is there's primary causes, which primary causes is there's something wrong with the valve itself that's causing this regurgitation, versus secondary causes. And secondary causes is something outside of the valve is causing the valve to leak. Okay? And when we talk about like dilated cardiomyopathy, that chamber gets stretched apart, which pulls those leaflets apart, and that causes the loss of integrity of that valve. So that would be a secondary cause, where it's not the valve itself that's the problem, something outside of it is causing it. So what are some common things that can cause primary mitral regurg? Well, mitral valve prolapse in the United States is the most common cause of this. Okay. Infected endocarditis. So we talked about how you have this thing that starts kind of eating away at the valve. That can cause the regurgitation. Trauma is there, rheumatic heart disease is there. So something that inherently damages the structure of the valve, causing the regurgitation, would be a primary cause. Secondary causes would be things like left ventricular enlargement. So you're getting that growth of the left ventricle. It pulls those valve leaflets apart, and then you get that leaky valve. Acute myocardial infarction. This would be like your papillary muscle ruptures, right? And now you lose that integrity of the valve to stay closed. So what's the problem with this? Well, if blood is supposed to be going from the ventricle out through the aorta, but I have this regurgitation, path of least resistance is going to be that blood from the ventricle is going to want to go to the atria instead of the aorta. Now I'm losing cardiac output, right? So that's going to be one of the things you're going to see, is that cardiac output disrupted. The other thing you're going to see is all of that volume is going to go to the atria, which is going to increase that pressure in the atria, because you still are having all that venous return coming from the lungs, right? And so you have volume, the regurgitation volume, plus the volume coming from the lungs. That's going to increase that pressure in the left atria. So you're going to see that left atrial pressure go up. But then that's also going to have to go somewhere. So it's going to go down to the ventricles again, which is going to increase the volume and pressure in the ventricle as well. So you can see those changes and those things going on with this condition. And unfortunately, that pressure and that excess volume doesn't just stay within the left side of the heart. It's going to back up into the lungs and cause pulmonary congestion there and all those kinds of things. So there is some upstream and downstream consequences of having this regurgitation. So you may be asking, well, what's going to affect the volume of the blood that's regurgitated? Well, there's 5 things that can do this. So what is the size of the opening during regurgitation? So is it this little tiny hole that only a little bit of volume can get through? Or is it a large hole where the entire leaflet is not closing, and now you have the whole valve basically regurgitating? Second factor is, what's the systolic pressure gradient between the left atrium and the left ventricle? So if the left atrium has a much lower pressure than the left ventricle, path of least resistance is to go to the atrium, right? Versus the aorta, sorry. But if my pressure in the left atrium is high, then, and especially if it's higher than going out and opening up the aorta, then path of least resistance in that case is going to be to go out through the aorta, because that atrium is going to be exerting a higher pressure for that flow to go in that direction. So that pressure gradient will be important. The other thing is systemic vascular resistance. This is your afterload. What is the afterload to open that aortic valve? Because again, path of least resistance, it's going to, the blood flow is going to want to go in that direction. And then left atrium compliance. What that means is, how willing is that atrium going to be to stretch out to accept all of this volume to keep that pressure lower, versus a stiff atria where just putting 5 milliliters of fluid in that area is going to rapidly increase that pressure. It's not going to accommodate that pressure, so that pressure is going to, or it's not going to accommodate that volume, so that pressure is going to rapidly increase. Okay? So that's what left atrium compliance and how that can factor the amount of regurgitation there. And then the duration of regurgitation. So is this mitral valve prolapse where the prolapse doesn't occur until the end of systole, and now I only have 3 milliseconds that it could regurgitate? Or is this happening the full duration of systole, and now you have that 300 milliseconds that regurgitation could occur? Okay. So the duration of that regurgitation will impact how much flow and how much regurgitation actually occurs. The other thing about regurgitation that you need to think about is, what are the acute implications of this? So this is, my valve is fine, it's fine, it's fine, and all of a sudden now I've got regurgitation. What is that pathophysiologic impact going to be? Versus this is something chronic where it's like, okay, just a little regurgitation now, a year later it gets a little worse, gets a little worse, gets a little worse. And you kind of give the atrium the ability to compensate for that extra volume. Okay? So are you allowing the heart to compensate for these physiologic changes? In the acute setting, so like rupture of an infarcted papillary muscle, rupture of the chordae tendineae, trauma to the chest, those would be kind of the things that we might think causing an acute regurgitation. And then chronic changes are things that take time. So rheumatic deformity of the valve, we said, takes 10 to 30 years to develop, right? So things that take time because the pathophysiologic impacts are going to be very different if this is an acute onset or if this is a chronic onset. With acute, what happens is the atria is going to have this low compliance, so it's not going to want to stretch to take on that volume coming back. So what's going to end up happening is that pressure is going to quickly rise, which then means that that high pressure in the atria is now going to impact the flow of blood in the pulmonary systems. Okay, so you're going to start to get that pulmonary congestion. They're going to have all those pulmonary symptoms, dyspnea on exertion, crackles, all that kind of stuff. At the same time, the other acute impact is because you're having all that blood flow going to the atria instead of out through the aorta, I now am losing cardiac output, and now I'm going to have exertional symptoms because I'm not having adequate cardiac output to meet my exertional demands. So that's going to lead to heart failure from that. Now, chronic mitral regurg, your atria is going to compensate. It's now had time to do the changes necessary to compensate for that extra volume. And so what ends up happening in the chronic mitral regurg is that left atrium is going to stretch out, it's going to stretch out, it's going to take all that extra volume, it's going to take out all that extra volume, and that pressure in the atria is not going to rise as quickly as it did in the acute setting. So now I can accommodate a much larger volume regurgitating before there are additional impacts, like affecting the pulmonary system. So what ends up happening in this case is pulmonary stuff may not be present, but you definitely are going to have that decreased cardiac output symptoms because all that volume is going up to the atria and not out through the aorta into the peripheral arterial systems. So our symptoms with this, so pulmonary, especially in the setting of acute stuff, but the clinical features are going to be pulmonary edema in acute, and in chronic, you're going to have that low cardiac output because more and more volume is going to regurgitate in the chronic setting than over the acute setting. On exam, what can you see or what can you appreciate? So in auscultation, the murmur you're going to hear is this like mid-systolic, early to mid-systolic decrescendo in pattern, or if it's in chronic, you're going to have this holosystolic murmur. And the reason in the chronic setting is, remember, S1 is supposed to be the mitral valve closing. But if you immediately have regurgitation occurring because that valve is not closing and sealing, you're going to have that turbulent flow going in the opposite direction for the full duration of systole. So you're going to have that whole holosystolic pattern. And if I'm going to do my dynamic auscultation maneuvers, I'm going to do my hand grip, which is going to increase my afterload. That's going to increase the pressure required to open the aortic valve, which then means path of least resistance and regurgitation again is going to be going to the atria instead of opening that valve. So you're going to have a louder murmur with hand grip in this case. Other things you may see, kind of depending on acute versus chronic, and also just the severity of it. You may have apical frills, so you're going to have like that vibratory sensation. Soft S1 with wide split S2, and loud P2. So there's some other kind of common things, but the biggest thing to know would be this holosystolic murmur present that also radiates to the left axilla. Ancillary studies, what can you see? So EKG, you can get the P mitrale because of that left atrial enlargement. Okay, so you can get that left atrial enlargement, so that P mitrale. But what we didn't talk about when we talked about mitral stenosis was changes to the left ventricle, right? We talked about right ventricle and right atria changes with mitral stenosis. But we didn't talk about left ventricle because that left ventricle isn't experiencing all of that extra pressure necessarily because it's going to squeeze like it should. So, but in mitral regurgitation, all that volume and all that pressure is going to have to come back to the ventricle. So it's going to have to compensate for that extra pressure and that extra volume. And it's going to do that by encouraging growth of the muscle, the myocardium, and you're going to have this left ventricle hypertrophy associated with that. Chest X-ray, you can see a bunch of pulmonary stuff. You can see the, especially the left ventricular enlargement or hypertrophy and the left atrial enlargement. You can see that cardiomegaly developing associated with this as well. Echo is going to be your test of choice because, one, you can appreciate the changes to the heart chambers or cardiac chambers themselves, but now you're also going to be able to measure the degree of regurgitation flow that is occurring. And what are the secondary consequences of having that flow going back? So echo will be your test of choice in this setting. How are you going to treat it? Well, if this is an acute mitral regurgitation, and we said acute mitral regurgitation, you're going to have that pulmonary congestion as the major complication associated with it. I need to do things to reduce my afterload to encourage that flow to go out of the ventricle and past the aortic valve, as opposed to having it go to the atrium instead. So let me reduce my afterload to encourage that forward cardiac output. And we can do that by doing like IV nitroprussides. We can do other like more mechanical kind of things like intra-aortic balloon pumps. Let's bring them to surgery and fix that valve that's giving the problems in the first place. But we want to avoid meds that slow the heart rate down, like your beta blockers or your calcium channel blockers like DILT and verapamil. Because remember, if I slow my heart rate down, I'm also increasing my diastolic filling time, which then increases volume and pressure that the ventricle is experiencing. So I'm going to overwhelm that ventricle. So let's not slow it down necessarily too much in the acute setting. Now, if I have chronic mitral regurgitation, and if it's primary, so the valve leaflets themselves are the problem, we're going to fix the valve. Okay. If it's secondary causes, so things like dilated cardiomyopathy, left ventricular hypertrophy, things that pull those valve leaflets apart, I'm going to want to address those things specifically to try to stop that stretch, stop that hypertrophy, so that those valve leaflets come back together and work to seal that one directional flow. Okay. Let's finish up with mitral valve prolapse and we'll be done for the day. So mitral valve prolapse is a separate entity from regurgitation. So, but you can have regurgitation with mitral valve prolapse. So not all mitral valve prolapse is going to have regurgitation, but the most common cause of mitral valve, the most common cause of mitral regurgitation in the United States is mitral valve prolapse. So I know that's kind of semantics and kind of whatever, but just because you have mitral valve prolapse does not mean you have mitral regurgitation as well. Okay. Because the prolapse itself is simply the valve leaflets are having an excessive extravasation into the atrium. So it's greater than 2 millimeters. But if that valve leaflets go backwards 2, 3 millimeters, but they still keep the valve closed, you're not going to have regurgitation. But what can happen is that backwards excessive movement of the mitral valve goes back, and now you're talking about 3, 4, 5 millimeters, it's going back. That will then start to open up those valve leaflets, and now you have that regurgitation. Okay? So That's how mitral valve prolapse can lead to regurgitation, but it doesn't necessarily mean that you are going to have regurgitation even though you have mitral valve prolapse. And this is super, super common, especially in the females in our population. About 2% of our population have mitral valve prolapse. Most common cause, primary cause of mitral regurgitation in the United States. There could be a genetic component to it, but it could also be associated with conditions like connective tissue diseases like Marfan's or Ehlers-Danlos, where you already are having kind of that hyperelasticity associated with that connective tissue disease. So those may be causes of mitral valve prolapse in our population if they have that. How are these patients with mitral valve going to present? Well, vast majority of our patients with mitral valve prolapse are going to be completely asymptomatic. The only way they're going to know that they have mitral valve prolapse is we tell them when we listen to their heart. Okay. We hear that kind of clicking sound associated with that prolapsing of the valve leaflets. If they have regurgitation, though, their presentation is going to be dependent on how bad that regurgitation actually is. If it's just a little bit, not a problem. But if it's a lot, then they're going to be presenting with severe regurgitation and with symptoms associated with that. So, one interesting thing to point out about auscultating mitral valve prolapse is your dynamic maneuvers actually can change this murmur to help you kind of differentiate. So if I stand or Valsalva, so kind of thinking about like afterload, preload kind of things, I'll have the click and the murmur that occurs earlier in systole. But if I squat, where now I'm decreasing that venous return, then it's later in systole. And this is what you see. So normal, okay, you may get that mid-systolic click and then regurgitation murmur if it's present. But let me decrease my preload or my venous return by standing or Valsalvaing. And then what ends up happening, because I have that decreased return, is that click is going to occur earlier in systole. And then if I increase the venous return, so I squat, like I said the other way around, if I increase my venous return like squatting or leg raising, it's going to delay that, and it's going to cause that click to occur later in systole. You might be wondering, well, why is this the case? Well, if I increase my venous return, like I do in this setting, that chamber is going to get bigger. So the ventricle is going to get bigger. I'm adding more tension to my chordae, which means I'm adding tension to my valve leaflets. So it keeps that integrity of the valve longer until that chamber starts to shrink, because all that blood flow is now going out into past the aorta. And now that tension on the chordae starts to decrease. Now I get my prolapse, and now I get my regurgitation. Okay? Flip it around, if I decrease my venous return, now that chamber is not going to be as dilated, so that chordae, the tension on that chordae is not going to be as much. When the ventricle starts to squeeze and I start to have some flow going out through the aorta, or the aortic valve, that tension is going to decrease on my chordae. Now I get my prolapse, and now I get that regurgitant flow earlier in systole. Does that make sense? Why? So it comes down to that tension that's being exerted on the chordae from that stretch and that volume in the ventricle itself. EKG with mitral valve prolapse could be completely normal. Really going to depend on if regurgitation is there and if it's severe enough to cause left atrial enlargement or left ventricular enlargement. Chest x-ray, again, most likely going to be completely normal, not going to be helpful in the diagnosis of this unless you have a severe regurgitation that's causing pulmonary congestion. Your echo is going to be your test of choice because you're going to actually be able to see that prolapse, measure the degree of that prolapse, but then also measure the degree of regurgitation if it is present. How are you going to treat it? Well, most of the time, just reassurance. We don't need to do anything about this if they're not having any symptoms related to it. If it's just the clicking because of that prolapse, we don't need to do anything about it. But if they have severe regurgitation, then they meet the criteria for when we talk about mitral regurg for the treatments. They'll meet that that criteria for treatment. But we don't really have to treat it unless there is that severe regurgitation associated with it. Now, one additional thing to consider is if you have elderly patients coming and seeing you and they're getting dental procedures, they may say, I've got mitral valve prolapse, I need antibiotics for my dental procedure. This used to be the recommendation. Back in 2007, so a long time ago, we changed the recommendation where if you just have mitral valve prolapse, you actually do not need antibiotic prophylaxis for infected endocarditis anymore. But you may still have patients coming and seeing you in the primary care clinic saying, I have mitral valve prolapse, I need my antibiotic for my dental procedure. And that's no longer the recommendation. Okay, that's all I got for you today.